Hi, I'm Dr. Jack West, medical oncologist in Seattle, Washington. One of the biggest advances in the management of lung cancer, as well as many other cancers, over the last several years has been the introduction of immune checkpoint inhibitors, which started out in the treatment of lung cancer specifically for patients getting it as a second-line or later treatment for advanced or metastatic non-small cell lung cancer. But over the last couple of years, these agents have been increasingly used in the first-line setting for at least a subset of patients. And they're poised to be used more and more commonly in a broader range of patients as a first-line therapy, either alone or in combinations. And these agents are even increasingly being used in earlier stage patients in a curative setting. But with the introduction of these agents earlier and to a broader range of patients, we have the growing issue of acquired resistance to this therapy when it is effective. And of course, oncologists have been managing this issue of acquired resistance to our more effective therapies for decades in the setting of chemotherapy, and for a decade or more with our targeted therapies, agents like EGFR inhibitors and ALK inhibitors. But we don't have much experience in characterizing the patterns of acquired resistance or determining the best ways to approach acquired resistance to immune therapies, because we just haven't had many years of experience in managing acquired resistance, and many of the patients who have been responding well to immunotherapy continue to do so. So it's in this setting that a very new publication in the Journal of Thoracic Oncology by Drs. Scott Gettinger and colleagues from Yale really provides an important introduction to an intelligent conversation about this increasingly important topic. The group at Yale, of course, has been running many trials in immunotherapy for several years, and they have hundreds of patients who have received these agents, and they winnowed it down from reviewing the records to 26 patients who had had a good response to a PD-1 or PD-L1 inhibitor, either alone or in combination with another immunotherapy and agent like a CTLA-4 inhibitor. And these patients had previously had a good response and then demonstrated acquired resistance and progression to this therapy. In characterizing this group, the median time to acquired resistance was 331 days, or just around 10 months. And it's interesting that there was a difference between the patients who received immunotherapy as a first-line treatment and those who got it as a second-line or later therapy. Specifically, the patients who received immunotherapy as a first-line treatment developed acquired resistance after 7.5 months as a median time to acquired resistance, versus just a few days under a year for the patients who received it in the second-line setting or later. And this is interesting in that we really have been thinking of these agents as being more effective when given early. That's not necessarily the case for immunotherapy, although we're going to really need to think about this and how best to sequence chemotherapy, immunotherapy, and other options in the next few years as we get more data on first-line immunotherapy. Nevertheless, it's a provocative finding that we will need to look at more carefully as we get more data than just a couple of dozen patients. What they also noted that was quite interesting was that the survival of patients after acquired resistance was still very good. And in fact, 70%, more than 2/3 of the patients were still alive 2 years out from the time of acquired resistance. They had 3 patients who had developed acquired resistance after being off of immunotherapy because of a fixed duration of treatment on a protocol, potentially side effect issues or patient preference, and these patients had a re-challenge with immunotherapy at the time of progression while off of immunotherapy, and 2 of those 3 patients responded. Of course, that's not a definitive answer to what to expect more broadly, but it's an important proof of principle that patients can demonstrate a response after being off of immunotherapy for a while. What the Yale group also noted that I think is quite important is that the pattern of progression was very limited to a small geography within the body in the majority of patients. And in fact, 88% of the patients in that series developed acquired resistance in just 1 or 2 sites of disease, which was very commonly lymph nodes. And because of this, just over half, 54% of the patients, continued on immunotherapy after the time of acquired resistance. And 58% of the patients received some form of local therapy to treat their limited 1 or 2 sites of disease, occasionally surgery, more often radiation. And these patients did extremely well overall. As you can see in the figure, the patients who received local therapy had an overall survival that very typically went on many years beyond the time of acquired resistance. Now, it's hard to draw any cause and effect here because there's so much selection bias. The patients who received local therapy were the ones who were doing the best and had the least extent of disease progression. But again, it's an important principle that patients can continue to do well for years after limited progression of their disease on immunotherapy, and that local therapy can be very helpful. One of the principles in radiation therapy is the concept of the abscopal effect, which is that radiation administered in one area can actually stimulate immunoreactivity in other areas outside of the radiated field and lead to responses elsewhere in the body. It's not clear that that's what's happening here, but that is a potential contributor. So the key points, both good and bad. This is still a small study. As large as the program is at Yale, it's 26 patients thus far. And so we can't read too much into it, but it is clear that the pattern of progression is often very limited and that it is amenable to continuing immunotherapy and sometimes, and in many cases, having patients receive a local therapy to treat just the limited area or areas in which the patients are progressing. This is what we've routinely been doing for many years with EGFR and ALK inhibitors when patients develop very limited acquired resistance. And it seems that immunotherapy is also very amenable to this, and that could be a very good idea. The survival is extremely high for the patients who had limited progression. The vast majority of patients still alive a couple of years out. Rechallenge is a viable option. And it's interesting that the patients who had received immunotherapy as a second line or later therapy actually seem to do better. We're going to need to learn more about the optimal sequencing. In fact, this wasn't the first foray into the question of treatment beyond progression, and Dr. David Gandera and colleagues presented at ASCO 2017 a report on the OAK study, which was atezolizumab versus docetaxel as a second-line therapy. And in this study, the patients who continued on atezolizumab, which was actually the majority of the patients when they developed progression on atezolizumab, did do very well and seemed to do better than the patients who even switched to another therapy or those who stopped all treatment at all, suggesting that there is still benefit to continuing beyond progression for at least some patients. Again, this is subject to selection bias. The patients who were most likely to stay on therapy were the patients who had the best performance status, had been doing well, and importantly, in the second line setting at least, or later, there are not that many alternatives that might be considered attractive. It's a little different in the first line setting, but another suggestion that there can be a benefit to treatment beyond progression. And Julie Bramer and colleagues also looked at the question of time that the patients did well before their second progression, or progression-free survival 2, they called it, when they switched from chemo to immunotherapy versus immunotherapy, like in this case pembrolizumab first line on the KEYNOTE-24 trial, followed by subsequent therapy. And in this analysis, they saw that the patients who started on pembrolizumab and then switched to a subsequent therapy had a very long time before they had progressed on their second treatment compared to those who started on chemotherapy. Again, getting into this question of optimal sequencing, they have their data looking at progression-free survival and even overall survival. And this was not the primary endpoint of the study, but it is an important question that I think we're going to be asking more and more. And so, in addition to potentially continuing immunotherapy after progression, the question is whether chemotherapy, too, could have a greater efficacy after acquired resistance. And that's actually a topic that has gotten some increasing discussion and some data in the last year or so, and I'll turn to that in the next video. Until then, I would welcome your comments in various settings in YouTube or on my website, and I'd encourage you to like, comment, and subscribe. I'd love to hear from you. Take care.